Welcome to APMA Online CECH. I am Dr. Diane Tower, APMA Director of Clinical Affairs, and I'll be your moderator today. APMA is pleased to offer its members free continuing education contact hours, or CECH, on a variety of topics. These live webinars will be recorded and are provided complimentary exclusively for APMA members. This is week 5 of the series, and we are going to hear about current literature related to Hammertoe fixation techniques, how to avoid recurrence of the deformity, and improve longevity of this commonly performed podiatric procedure. Next slide. APMA has approved this activity for 0.5 CECH, and no commercial interest provided financial support for this continuing education activity. Next slide. We will have a few minutes at the end of today's webinar to address questions. So if you have questions throughout, please type them in the questions box in the Go To Webinar toolbar. We will address as many questions as we can in our allotted time and apologize in advance if we can't get to all of them. I want to introduce our speaker and get right to the presentation. Next slide. Today we have Dr. Rachel Albright, podiatrist at Stamford Health Medical Group in Stamford, Connecticut. Dr. Albright has no relevant financial relationships related to this webinar to disclose. And I will hand it over to Dr. Albright.
Thanks so much, Dr. Tower and APMA, for inviting me here to talk about this topic with you. And I think most of us are here today because we've said to ourselves at some point in our practice, hammertoes are tough, and they're actually more tough than I ever thought that they should be. So intraoperatively, they're technically pretty simple. Most of us don't have much of a problem taking a deformity, even at multiple joints in multiple planes, and making it look really straight, both intraoperatively and immediately postoperatively. So I don't think the issue is really going on in the operating room, but it does seem to be going on long-term. The long-term outcomes are pretty unpredictable after hammertoe surgery. When we look at recurrence rates in the literature, they're really all over the place. There's some articles that say they've had a 0% recurrence rate, no failures at all. And then we've had articles with failure rates as high as 50%. So that tells me that this is a really unpredictable surgery that we haven't quite mastered yet. And if that's not concerning to you, it should be, because podiatrists perform more hammertoe surgeries than anyone. This is a survey done in 2010, so it's a little bit outdated, but I would like to think that podiatrists are still doing a lot of hammertoe surgeries today in 2020. But you look at hammertoe repair here, and podiatrists do more hammertoe surgeries than orthopedists or any other physician. So the fact that recurrence rates are all over the place and where the physician's doing the most of it, it's kind of our responsibility in some way to figure out why we're getting so many failures and how can we eradicate it. I think fixation does play a role in this. There's been many advancements in fixation since it was first described. So just a really brief history lesson. In 1940, Taylor published a case series of 12 patients who underwent K-wire fixation for arthrodesis of the PIP. And he said he got excellent results back then. So since 1940, we've really been using K-wires to fixate hammertoes. Fast forward to the 80s, Coughlin, he published a textbook chapter, and he really published on techniques for surgical correction of hammertoes. He was one of the first people to really describe how long K-wires should be left intact. So he left his intact 3 to 4 weeks at that time, and then he taped the toe down for an additional 6 weeks after that. Coughlin again in 2000 had another hallmark article. He had 61 patients that underwent K-wire fixation. And the reason why I like this article is because this is one of the first times that we've seen a nice detailed review of the complications that can arise. Up until this time, a lot of authors would just give 1 or 2 lines about the complications they would get, but Coughlin spent a decent amount of time talking about his complications, and he went over patient satisfaction, why patients were satisfied, and what things he thought were contributing to their satisfaction. So it's a pretty interesting read if you ever want to look into it. He actually had a 10% complication rate at that time. Ever since 2000, there has been advancements in fixation, and they've really been aimed at trying to improve these complication rates and these outcomes. And now, no surprise, we all know that the 2 competing strategies that we're really talking about is K-wires or implants, right? These are the two on the market that are most viable, that show the best results. And there's really pros and cons to each of them. So some of the pros of K-wires is it's definitely the most researched one. It's been around longer, pretty good results in the literature. But some of the cons are there does seem to be an increased risk of infection with this percutaneous wire sticking out of the skin, pin tract infection. The aesthetics of it, the patients don't really love having a K-wire sticking out of their toe. And then for the implant group, a lot of the good things about implants are trying to improve on the cons of K-wires. So the pros of implants are a lower risk of infection, right? So the implant is inside of the joint, better aesthetics for the patient. There's also some literature saying that there's probably some better osseous union rates with an implant. But the cons of implants are definitely the cost, they're definitely more costly than K-wires. And if you ever have an issue with the implant where it needs to be removed, there does seem to be some difficulty with removal. So some of the things that really stick out to me personally is, first of all, the low cost of K-wires obviously attracts me to it. And then the fact that it's the most researched. Now, anyone who knows me well knows that I really look to the literature to make decisions on what I'm going to do clinically and surgically. So this gives me confidence in K-wires that it's one of the most researched methods that we have. But the thing that really attracts me to implants, on the other hand, is this quicker return to shoe gear. In my patient population, I tend to keep people with the K-wire intact for 4 to 6 weeks, kind of more leaning on the 6-week side in a post-op shoe. So when I put an implant in, they don't have anything sticking out of the toe. So I'm tending to get people back into a regular shoe in like 2 to 3 weeks. That's a pretty significant difference. And the return to shoe gear is way quicker in the implant group than the K-wire group for me personally. So that's something that really attracts me to the implants. So I'm going to take just a minute here and try to convince you that it does matter what literature you look at when you're looking at therapeutic type literature. So when we're talking about a drug or a surgical technique or an intervention or just some kind of therapy that's being administered to patients, it matters what type of literature we look at. And I'll show you why. If you have a control group in your article, it allows you to compare between the procedures and allows conclusions to suggest that one procedure is better than another. If you don't have a control group, you can't make any conclusions that the intervention is better than anything else. So with K-wires and implants, we kind of know at this point that both of them are pretty good. And what we really want to know now is which one is better. So for the sake of that argument, I'm only going to show you literature that has a control group because we want to know what's better. So this is a table that I put together of articles basically in the last 20 years or so that was a head-to-head comparison of K-wires versus implants. And there's not many. This is basically the last 20 years here. And this first article here was a cadaveric study. So it really only looked at constructs, and it found that K-wires provided stronger constructs than implants. This second study did not perform a statistical analysis, so we can't really make any conclusions on which were better. This study showed that the implant group had fewer complications, so that is probably 1 point for implants there. These next two studies showed no statistically significant differences, so they were basically the same. This study showed that K-wires were more effective when it comes to costs and outcomes. This study showed improvement for all groups, K-wires and implants alike, with no real statistical significant differences. And this last study showed that the implant group experienced better union rates and better quality of life scores, but only in the first 6 months, so really early postoperative period. In my opinion, the first 6 months is probably not long enough. I don't think many of us are really having a lot of trouble in the first 6 months out from surgery. It's really a couple years down the line that we might see people come back in and say, hey, my hammertoes deviated again. So I actually don't feel like that is particularly very helpful. But really what you're probably seeing from this is we don't really have an overwhelmingly amount of literature saying that K-wires are better than implants or implants are better than K-wires. It seems that when we're looking at outcomes, they're basically the same. So how do we make the decision if we should do K-wires or implants when we're doing hammertoes? And some of you might be thinking, well, this is fantastic because it means that it's surgeon's choice. It's a dealer's choice what I want to do because the outcomes are the same. And in a perfect world, maybe, but I think the healthcare system is going to beg the surgeons to look at the cost because they don't cost the same amount of money, right? So we did do a study, a cost effectiveness analysis looking at K-wires versus implants. Now, the idea behind these cost effectiveness studies is that sometimes higher costs are worth it to gain more. And this is especially true in things like cancer research. So for example, the healthcare system is absolutely willing to pay more for a cancer drug that can either put people in remission faster, that can increase the amount of life years somebody has in their lifespan, or can significantly increase their quality of life. And the healthcare system is absolutely willing to pay more for that because they recognize that higher costs are worth it to gain more. So that's what we were trying to see in this article. Are the higher costs associated with implants worth it? Because we're gaining more from an outcomes perspective. And the bottom line is we found that the extra cost associated with implants actually was not justified. So even though implants were slightly better than K-wires when it came to outcomes, they just weren't good enough. So there's two things that implants needed to do to kind of fix this. They either need to lower their cost or they need to be better. So if they cost less than $300, it would make them a little bit more cost effective. And if you could prove in the literature that they perform significantly better than K-wires, that would probably make them more cost effective, but it would need to be a head-to-head comparison. So you would need to have an intervention group and a comparison group in order to prove that. Just some clarification on this article. I don't want you to think that this article is saying that there's no place for implants in surgery, because that's not what we're trying to say. But what we are trying to say is that surgeons should engage in shared decision making before they make the decision on if an implant should be put in or if a K-wire should be put in. So there will be patients in your practice that are going to prefer an implant for several reasons. Maybe they have pets at home, so they don't want a percutaneous K-wire. They're afraid their pet's going to get, lick it or something. Or maybe there's patients that need to get back into shoe gear quicker because they can't take off work. These are all reasons why a patient might want an implant. On the other hand, there are patients that do not want retained hardware in the joint, and they're willing to be in a post-op shoe for longer in order to not have retained hardware in the future, because that K-wire just gets pulled. As a surgeon, you're never going to know which patient is which unless you ask them, right? So we need to have conversations with patients and figure out who is the best patient for which fixation type, and then make the decision. So for surgeons who are routinely using implants on everyone and not having a conversation with the patient, this article is meant to challenge you a little bit, because there's really no proof that implants are producing better outcomes than K-wires, and really all you're doing is surgery that's producing no better outcomes, but you're costing more to the healthcare system for no benefit. So that's just kind of something to think about. But let's talk about recurrence. I did promise I would relate this back to recurrence somehow here. So going back to our slide of recurrence rates, we know that it's a bit all over the place. And we did a study recently looking at what are the risk factors for failure in Hammertoe surgery. So we wanted to identify patient and surgeon factors that could be associated with failure. We looked at multiple techniques for reducing the PIP joint. So these are all the techniques we looked at. We can see a percutaneous K-wire group, a commercial implant group. Now, just a caveat, this is not the only commercial implant we looked at. We did look at others. This is just an example for those of you that recognize that type of implant. We also looked at less commonly done procedures, like this phalangeal osteotomy on the far right here. We looked at patient and provider factors that could be predictive of failure. So our patient factors were more demographic, age, gender, BMI. We looked at which toe was involved, and we looked at whether the patient had comorbidities, etc. The provider factors were really centered around what surgical technique did the surgeon take to correct the PIP and the MTP joint. We also did a radiographic analysis because we wanted to see if preoperative deformity was predictive of postoperative failure. So we looked at the degree of the deformity on x-rays. It's just an example of that. So these are the results that we had, and I highlighted the things in red I thought you should pay attention to for those that don't really want to read a lot. And we had 152 patients. That's 311 toes. The mean follow-up was 2 years, and the mean time to failure was about 16 months. So a little over a year is when these started to kind of fail on average. 68 toes had suboptimal outcomes out of the total 311. 67 of them went on to get revised, and one person was symptomatic but elected not to have surgery. Most of the reasons for revision was some kind of painful recurrence or malalignment in the toe, but 20 people did have a hardware complication. So this was our final model for predicting failure. This is all 311 toes here. So we found that if a concomitant first rate procedure was done, this actually resulted in a protective effect against failure. So that means if a person had a hallux valgus deformity and you chose to fix that hallux toe that was a butt in the second toe, that person had a 50% reduction in failure rate. They were 50% less likely to fail in the future. Now, this has been anecdotally talked about in our circles that fixing hallux valgus might have a protective effect, but this is one of the first times in the literature that we know of that we've actually been able to prove it statistically. So we were pretty happy to finally get this out in the literature there. We also found that transverse plane deviation was a risk factor for failure. So this is an example of measuring the transverse plane. We looked at it at the MTP joint and the PIP joint and basically added those angles together. With the hazards ratio of 1.03, that equates to a 52-degree transverse plane angulation seen here equates to a 2.5 times greater risk of failure compared to a toe that had no transverse plane deviation. Now, this is pretty interesting because by definition, a hammer toe is a sagittal plane contracture, right? So all of our techniques and all of our tools are really aimed at fixing the sagittal plane. But the sagittal plane is not a risk for failure, at least in our model. Only the transverse plane was a risk for failure. So how are we fixing the transverse plane? Some of us are probably fixing it with fixing the collateral ligaments, doing some soft tissue work, reefing that up. And if then that still doesn't look good, maybe we're taking a K-wire and we're driving it back into the metatarsal head and then we're forgetting about it. And we're just like, yep, that's how we're gonna fix transverse plane. So I'm going to show you a little bit later that might not be sufficient. So I'll tell you a little more about that later. We also found that the second toe was more likely to fail than the third or the fourth toe. So this is kind of a visual depiction of that. The second toe is in red here on the bottom, third and fourth toes are in blue on the top. At about 2.5 years out from surgery, you see that those lines are starting to diverge and second toes are failing at a faster rate than third and fourth. At 1,500 days post-operatively down there at the bottom, 50% of second toes are failing. Now, when I first saw this, I was a little bit scared because that means that I probably have a ton of failures out there because I'm not calling people at 3 years out and saying, hey, can you come in and can I see if your toe failed? Like, I'm not doing that. And most of us probably aren't doing that. So this is really a call for anybody who is doing research. Please publish data 3 years out, 4 years out, because we want to have a better grasp on how much of a failure rate do we truly have, because I don't think we're following patients probably far enough out from a research standpoint. So that's just kind of something to think about here. So we were able to come up with some non-modifiable and modifiable risk factors. There's not much we can do about the second toe being the one that's involved, but some things we can correct is the hallux valgus. If somebody has a hallux toe that is abutting the second toe, they have a bunion deformity, and you correct it, that can give them a 50% rate reduction in failure down the line. They're 50% less likely to recur down the line. Addressing the transverse plane, is there something we can do more intraoperatively to address this? And I'm going to talk about that in a minute. Another risk factor for failure we found is less common procedures for PIP joint reduction. So phalangeal osteotomies, some of us do this, some of us don't. But we actually found that that was a risk for failure. So we would recommend avoiding staying away from these less common procedures. Okay, so some of you are probably saying, what about fixation? So how does fixation fit in? Did K-wires or did implants have some kind of association with failure? And the answer is no. So here they are here, your K-wire versus your implant group. The p-values were not significant. So this is another study showing that the outcomes as far as failure are the same between the groups. Let's talk about transverse plane considerations here. So in this study, they looked at wild metatarsal osteotomies and they looked at translation of the head in order to fix the deformity. So you can see that here, this head is medially translated towards the first ray in order to make that second toe rectus. I really like this photo. This is straight from their article. You can see here on the left, picture A, this second toe has been fixated at the PIP joint with a wire, and the metatarsal osteotomy has been made, but that second toe is still medially deviated. But in picture B, they move the head over, and that second toe is all of a sudden straight. So I thought that was a really cool photo that they included. This was a very small case series of patients. They only had 5 people included in this. 1 person postoperatively had a floating toe. They did have a 2-year follow-up, so overall their results were okay, but they only had 5 patients included. This is another study. This looks at second MTP joint arthrodesis. So this is something we don't see very often, where we're fusing the lesser MTP joints. But they only did this in really severe deformities. So really severe crossover deformities. They had 11 patients total, 19-month follow-up. And they found that they had no recurrence and no transfer lesions, which is surprising. I would think that there would be transfer lesions, but they reported none. And they fixated the MTP joint with both a K-wire and a staple. So they had pretty good results as well. This last study I'm going to show you is a report of 25 cases. Again, it's a while osteotomy and it's translated medially towards the first ray. They had 25 patients. They had a follow-up of 37 months, and they had a 30% floating toe post-operatively. They had no recurrence of metatarsalgia, but they did have 1 recurrence of transfer metatarsalgia, and they said it was because they thought the first ray was not shortened enough. They also did some while metatarsal osteotomies on the lesser metatarsals in order to maintain the parabola. So these are some articles that I was able to find on osseous procedures for transverse plane deviation, because we've found that transverse plane deviation is a risk factor for recurrence and not sagittal plane deviation. And right now, it doesn't seem like we have really great things to help us fix the transverse plane. For severe deformities, it might be necessary to do osseous procedures like the one I just showed. And I'm going to tell you, that was only 3 articles, really low sample size. So I can't really say with certainty that this is a great procedure and everybody should be doing it. But I have anecdotally talked to some of my colleagues who said that they do this. If you've been doing this for years, please publish your results, because I'm really curious about this procedure. I can tell you that I'm doing this now. I don't have a high enough sample size yet to really publish, but I am doing it. Anyone who's been doing this for years, please publish your results, because I would be really interested to know if this is working or not. Take-home messages besides the transverse plane deviation is second toes are more likely to recur than third and fourth. There's not a ton we can do about the fact that the second toe is more likely involved, but we can correct the first ray. There is a protective effect if the hallux valgus is corrected, and those people are 50% less likely to have a failure. And the last take-home message that I want to share is shared decision-making should be employed before using commercial implants. And that's because there's really no literature that proves that implants are better than K-wires. So if you're routinely using implants, it could be a source of healthcare waste, because you're not producing better outcomes, but you're spending a little bit more. So I would really encourage surgeons to use shared decision-making and only choose implants based on the patients who really need them. Thank you.
Thank you, Dr. Albright. And we do have a few minutes for Q&A. So before our first question, though, I will note that the link to today's evaluation for the webinar was shared in the questions box in the GoToWebinar toolbar, and will also be shared with attendees via email. You must complete the evaluation in order to be eligible for CECH, and you will have through June 7th to complete the evaluation for this webinar. And certificates will be sent via email to the email address you used to register for today's event within the next 2 to 3 weeks. So Dr. Albright, we do have a few questions, and I'll lump a few of them together here because they're very similar, just talking about different types of fixation. So have you ever used absorbable K-wires? What about no fixation? And what's your opinion on peg and hole?
Yeah, good question. So I'm actually going to go back a little bit in my slides, because this slide So we actually did look at resection arthroplasty with no fixation. And there has been literature in the past that has said that fixating something with a K-wire has a better outcome than no fixation at all. However, in our study, the way you reduce the PIP joint had no difference. So the literature is kind of non-conclusive about no fixation. As far as absorbable K-wires, I've never used those, but I don't think we used those in this study, but no, I've never used those. And then to answer the question about the peg and hole, that's actually the technique most of us did for our arthrodesis. That's something, I just feel like you get better approximation of the joint, but there was a lot of surgeons that didn't use that. We actually had 9 surgeons in our study, so you can imagine that the surgical techniques were kind of all over the place. And that's why surgeon factors was one of the things we looked at. And we didn't really find that the way a surgeon chose to fixate the joint or prepare the joint had any difference.
Great, thank you. The next question for you, Dr. Albright, is can you talk a little bit about the biomechanical pre-op evaluation and then any intraoperative considerations that you take based on that?
Yeah, so preoperatively, as far as biomechanical stuff goes, is specifically for Hammertoes, I mean, the things I'm really looking at are, is it flexible or rigid, you know? Because I actually don't do arthrodesis on everybody. And that's one thing that I don't love about implants, because I feel like the only thing you can do is really fuse it, right? So if I want to do an arthroplasty, which I actually do with flexible deformities, K-wire is kind of the only way to go. So preoperatively, I am looking whether it's flexible or rigid. I am looking to see if there's a bunion, if the other toes are involved. I do look for metaductus on the x-ray. And if there is a little bit of metaductus and it's causing some transverse plane deviation at that MTP joint, I am moving that head over. Intraoperatively, I'm actually not driving the K-wire into the head because I feel like when that K-wire gets removed, I mean, at least in my people, it kind of starts drifting again, like a little bit down the line. So I'm not really relying only on that soft tissue scarring, which I know a lot of people rely on. And I was actually taught that in residency, but I don't rely on that anymore. I actually move the head over. So those are some considerations I do intraoperatively. I really am kind of addressing the transverse plane more.
And I'll ask 2 final questions again together here. Can you talk a little bit about any consideration or repair of the plantar plate and or if you ever cross the MPJ with your K-wire?
Yeah, so I do fix the plantar plate if the person has pain sub-second, or if there's a lot of transverse plane deviation, I'll fix the plantar plate, even if I don't really suspect a tear. And I can't really tell you why I do that, I just do it. But I actually had a patient really recently, I wish I would have put her pictures in the slides, but she actually had an acute plantar plate injury, so she had no hammer-toe problem at the PIP, and her biggest complaint was dorsal floating and then medial deviation. So I did the wildman tarsal osteotomy, I moved the head over, and that got it nice and straight, and obviously I had to fix the plantar plate. The issue I have been finding with fixing the plantar plate is stiffness postoperatively. So I think that getting people into PT early is pretty important to reduce stiffness, but it's really a trade-off. You get people into PT early, you'll reduce the stiffness, but you have a higher likelihood of a floating toe. So that's the trade-off I have with people preoperatively, is I'll say, is it more important for you to be really loose at that MTP joint, or is it more important for you to have that toe sitting on the ground? Because that's the trade-off I've really had with people, and I let them choose. And then postoperatively, whatever happens is something that they chose. So that seems to be working well for me. But I do fix the plantar plate if the deformity is severe. If it's not very severe, then I won't.
Thank you so much, Dr. Albright. I want to thank you all for joining us this week 5 of the APMA Online CECH series. As we mentioned last week, as a result of the outstanding response to the APMA Online CECH series, We are extending the offering by an additional 2 weeks for an extra 1.5 CECH, which means we hope you'll join us next Thursday, June 4th at 12 Eastern for 1 hour as Dr. Joshua Lenchis discusses the epidemiology of and efforts to address the opioid epidemic, as well as analgesic interventions. More details regarding week 7 to come soon. Check out www.apma.org/online-CECH for the most up-to-date details about the series. Thank you and have a great day.